Hello, everyone, and thank you for joining the webinar today. My name is Jacob Hayden, and I am a coordinator for SaferSim University Transportation Center. Our webinar today features work from researchers at the University of Iowa. Dr. Tim Brown and Dr. Gary Gaffney will be presenting their research evaluating drug driving. During their presentation, feel free to use the chat box with any questions or comments. We will also have a question and answer session at the end of their presentation. And with that, I will let the presenters take over from here.
Thank you, Jacob. This is Tim Brown, and with me is Dr. Gary Gaffney.
Hello.
For those of you who are in baseball mode, we're gonna try and do this. I'll be play-by-play, and Gary's gonna provide the color commentary. We've got a couple of students that are working with us here, hanging out with us in the presentation here. We look forward to any questions you guys might have as we go through this. There's a chat box that you can put them in. We'll try to attend to those as we're going through if you have questions as we go. Otherwise, we'll answer them at the end if there doesn't seem to be a good fit as we're going. So again, we want to thank you all for being here with us today as we talk about the effects of pain and anxiety medication on driving. I should point out Gary Milavetz, who is the pharmacist on this project, is not able to be with us today. And I also want to give thanks to Andy Spurgin, who was a research fellow from pharmacy who was involved heavily in this research during his time here with us at the National Advanced Driving Simulator.
And great thanks to SaferSim who funded our work.
So the problem, and again, we'll start off with the larger problem, which is 18% of motor vehicle deaths are caused by drug, not including alcohol. So there's a big chunk of motor vehicle fatalities that are the result of, or in part caused by, being under the influence of impairing drugs. And these drugs can be either prescribed or illicit, or sometimes they are prescription medications that are being used not in accordance with their prescription. Annually, more than 10 million people in the U.S. admit to driving under the influence of illicit drugs, and so I think that's a big challenge. You know, when we try and talk about it from the standpoint of drug impaired driving, NHTSA does a good job of every few years going out and doing a roadside survey to try and get an idea of what is in the bloodstream of folks who are driving on our nation's highways. And there are a lot. And when we look to our pharmacist friends, you know, they'll point out that, you know, was it half of the population is on 2 or more drugs at any given time. So that's a big number, and it has a great potential for problems due to some of the side effects associated with these drugs.
And I will point out that there are drivers who likely innocently take a combination of medicines, not totally understanding the impairments and the side effects, although there are warnings on the bottles. But that's been the thrust of some of our research, the unintended consequences of those side effects, such as sedation of these medicines.
So as we go through as we continue talking about the problem, we can go through the different classes of drugs, and this is kind of the top 6 from the list of fatalities or drugs that are in people's systems when they've been involved in fatal crashes. And again, correlation isn't causality, but you know, the big ones are marijuana, again, leaving out alcohol, tranquilizers such as benzodiazepines, opioids, stimulants, antidepressants, and antihistamines. And as Gary can attest to, you know, antihistamines are one of those things that a lot of people take for their seasonal allergies, but a lot of them have sedation effects that go with them. Opioids are drugs that people often take to manage pain, but they have side effects, and you know, looking around the U.S. these days, we have the issue of opiate overdoses that are going on across the country in various states, where we're seeing an increase in emergency room admits for people who have overdosed on opioids. So the aim of this research was to assess the effect of benzodiazepines and opiates alone and in combination on driving performance. Now, this kind of extends some of our previous work that we've done that's looked at things like caffeine and antihistamines, looking at stimulants such as ADHD medications, Adderall, diphenhydramine, and our work on cannabis and driving performance. So one of the things that we're of interest here, particularly as it relates to the benzodiazepines and partially to the opioids, is what are some of the other effects that get pulled in here? You know, how big of a role does sedation play? And so, as we went through, that was an area of special attention, trying to understand what the level of drowsiness was for the drivers who are on these medications. So I'm gonna turn straight over to our color man here, Gary, to talk a little bit about the drugs. I'm an engineer, and I can tell you what drugs we use, but Dr. Gaffney can give you a little bit better perspective on those drugs.
Thank you, Dr. Brown. It's the first time you've admitted that. As a background, we're really indebted to Dr. Spurgin and Dr. Milavetz, who as pharmacists understand the prescription base and the statistics. First, we found it difficult to totally believe the data, not believe is not the right word, but that the data on the opioids, that generally that class of drugs and narcotics do not affect driving. But then we wondered about interactions with side effects, and we considered combinations such as opioids and soma or flexeril, which would be commonly used in pain. And then Dr. Spurgin, through his contacts and seminars and meetings, mentioned other pharmacists were exceedingly concerned about the combination of narcotics and benzodiazepines. And a frequent combination is hydrocodone. Now, hydrocodone, oxycodone are two of the most prescribed analgesics, most prescribed drugs in this country. And listening to him, I was a bit surprised that Alprazolam or Xanax was added in. That's pretty well known as a powerful sedative or anti-anxiety medicine. So that tells you a little bit about the background and where we were headed in the study. But the combination is Norco, which is a combination of, it's a fixed dose of hydrocodone and acetaminophen. That is for analgesia, but probably the secret is acetaminophen is added so that there's less abuse potential. You really can't inject Tylenol. The 10 milligram dose is not high. It's high-ish, but not high. I wanted a dose that we'd look at it with significant clinical effects. Hydrocodone can be used 5 milligrams, 10 milligrams, 10 milligrams, I don't know, every 4 hours, 6 hours is reasonable. But we wanted a dose with some impact. The side effects can produce some drowsiness, which may possibly impair driving. However, data indicates, mostly from Europe, that a stable dose does not impair performance. Now, there are questions about chronic use, acute use, and age. We couldn't obviously test all those factors in this more or less pilot study, but you understand the complexity of this. The next agent is Alprazolam at 1 milligram. That's a significant dose, even in a one-time use. Alprazolam can produce, and as we'll point out later, sedation. It's used for anxiety. It can produce amnesia and muscle relaxation. So you can see how that may interfere with cognitive and motor tasks. And then there's a side point. This combination it's difficult to track down the prevalence. It clearly can be used in outpatient procedures for analgesia. It can be used for treatment of cancer, for pain relief too. And as I recall, Dr. Brown, the statistic was this combination, I may be wrong on the specificity, is responsible for over 50,000 emergency room visits a year. Was it specifically hydrocodone and Alprazolam?
That's my
I think it
recollection
was.
from Dr. Milavetz's review.
Yeah, so although I can't tell you exactly the prevalence of this combination, that shows that it's not insignificant.
And so for this study, as Dr. Gaffney indicated, we really focused on a pilot study to give us some initial ideas of what the effects are going to be. And so we had 8 participants who possessed a valid driver's license. We set a threshold of 5,000 miles per year to basically set some minimum driving standards. So we've got people who are driving relatively frequently. And so we have a more stable estimate of driving performance in the baseline condition or the placebo condition. Participants were screened for common drugs. So we were looking for things that might impact driving performance. So, obviously one of the complexities of this sort of research is that you want a clean comparison and you can't have other things in the system when you're doing that. And so that creates the need to make sure that we get a clean urine drug screen that doesn't have anything else in the system before we dose them. We also were concerned about caffeine and alcohol use preceding when we ran the subjects. So for the 8 participants we had, they were evenly split by gender. We had a mean age of 30 years, which ranged from 21 to 40. And we in Iowa seem to drive a fair amount, 14,000 miles per year on average, with a range of 5,000 to 25,000 miles across the participants. So for the method, as I indicated before, this is kind of continuing the line of research we've used. And so we used some standard and validated scenarios to assess impact on driving performance. And so the scenarios we use are really a drive from an urban area to a rural area. And so one of the advantages of that is that we get driving performance in a variety of driving situations. One of the challenges with that is that we are sometimes struggling with whether or not we have a very basic driving situation that we can measure over a long period of time where the driving demands are constant, or whether or not we try to vary it. So the advantages of a constant are that we can look at the time course of the drug and we can see how that changes as the dose or the level of drug in the blood changes over time. One of the struggles we've got with that is that it doesn't give us an idea of how do people perform in a urban environment or on the interstate. Oftentimes that winds up being a long rural drive, which may not be fully representative of all of the driving situations people find themselves in. With the change in environment, one of the challenges there are that when you've got different environments, that you're at different levels in each of those environments. So if drugs change rapidly in terms of their levels in your blood, for example, with cannabis, you very quickly have when you're driving in the urban environment at the beginning, your blood levels are significantly different than when driving on the rural environment at the very end of the drive. And so, in considering those, we'd kind of gone the route of using the varied route, finding that was more valuable than some of the side or drawbacks. And so we've used this for things like alcohol research, cannabis research, drowsy driving research, distraction research, and then a slew of other drugs that we've studied. And so the participants first participated in a screening visit. So after we after we contacted them and they expressed interest, we brought them in, verified that they met the inclusion criteria. They underwent a general physical and psychological examination with no evidence of chronic disease that might affect driving. Again, they were screened for common drugs, and they were screened for motion sickness. We had them take a short drive, and we then checked to make sure that they weren't going to experience motion sickness during their subsequent visits. And once that was done, we scheduled them for 4 visits, approximately a week apart, or I should say a minimum of a week apart, where we would assess the performance. And so the week apart ensured that we didn't have carryover effects of the drug. One of the things probably to point out here, just to make sure it is completely clear, is this was an acute administration of the drug. So these were not people who were taking these drugs in combination in their daily life. These were normal, healthy subjects who came in and were dosed with those drugs on those visits. And so on one visit, they would have 2 placebo pills. On one visit, they would have Norco, acetaminophen. On the other visit, they would have Xanax, and on the 4th visit, they would have a combination. And those orders were randomized, so they got them in different orders for different people.
So a random crossover.
Yeah. Double dummy, double blind crossovers design.
And again, basically, it's a healthy, young, non-substance using study group. Now, you all can imagine that in real life, there's complicating factors such as exposure to these drugs, chronic use of the drugs, chronic pain, and other conditions. But this is the place to start, with the healthy group with no obvious physical or psychological problems.
Well, now we'll kind of walk through what one of their study visits look like. So the first thing that they did as they arrived, we had some intake surveys, and this was generally about 8 o'clock in the morning. And we drew a blood sample to get their baseline levels so we could later look at what the peak levels of the drugs were. They then were dosed with the 2 pills. We then waited about 2 hours or just under 2 hours for them to reach peak. And so one of the challenges with this is always, where is that peak time that you want to test at? And we, in this case, we were looking at 2 hours afterwards. And so we then moved on to EEG testing. And the work we're presenting doesn't include the analysis of the EEG data, but we did collect some baseline tests using EEG to assess what the impacts were on some basic tasks and look at what the brain activity was during that time. We then waited another 15 minutes. During that time, we took a blood sample. We then proceeded to the drive, had them take a Stanford Sleepiness Scale. They drove the simulator drive, which took about 35 minutes, and took another Stanford Sleepiness Scale. We then had some post-drive surveys, and then we transported them home. Obviously, with doing drug studies, we have to be very clear on some of the safety protocols, and so either they made arrangements to be dropped off and picked up, or we would make arrangements for them to be dropped or to pick them up and bring them here and then take them home. Obviously, we didn't want to dose them and then send them home on their own after having been dosed with these drugs.
The peak blood levels for Alprazolam about 90 to 120 minutes. Hydrocodone perhaps a bit quicker, but we had to coordinate between those and coordinate with the protocol. So you can see how the timeline was developed.
And I forgot to show the nice pictures I was going to click through. So there's the EEG machine that we used. It was a system from B-Alert, which has 10 leads. And there's a picture of somebody performing or having the testing set up. And we did collect EEG data during the drive as well that we will be analyzing. Always the fun needle sticks to get the blood. I'm not allowed to do that for various obvious reasons. A, I don't like blood, and B, I'm not qualified. And then C is a picture of the miniSim that we used.
And you'll notice on that prior picture, a butterfly was used just to inflict maximal pain, I think.
Yeah. I think that's not true. We'll
It
we'll go with that. Because this is being recorded, Gary, and we don't want to say that we've caused pain to subjects
We were
intentionally.
completely conscious of subject comfort and
Thank
did
you.
everything we could to make our subjects relaxed and comfortable.
As relaxed and comfortable as you can be when you're having your blood drawn. So I don't like my blood drawn, so I would never volunteer for this study. So that would be the kicker for me. So now we're going to move on to some results. And so kind of to start off here, we looked at, and I didn't throw this on a separate slide, but I could have. We looked at 6 driving environments, 2 in the urban area, 2 in the interstate, and 2 in the rural. All these were simulated nighttime driving, so nighttime driving conditions in terms of lighting. The urban was basically a standard urban drive with a lot where they moved around in a 2-lane urban roadway through a town area. Urban curves was a little bit more suburban, where they were going through a curvy area with 30-mile-an-hour curves. And then we have standard interstate driving, straightaways with interstate and interstate curves, with very gentle interstate curves as you might expect. Dark rural was a long segment where they negotiated a variety of curves while driving in a dark environment with relatively little lighting. And then a rural straight, which again, as we talked about sedation, is a 10-minute segment at the end. And it's the only portion of the drive that's timed, and it takes 10 minutes. Whether you go 5 miles an hour or 100 miles an hour, that portion of the road, that portion of the drive lasts exactly 10 minutes. And so speed doesn't have an impact on how quickly you finish. It just it deals with how much distance you cover. And so we focused on these driving environments largely because they are devoid of some of the other complications. So for example, we didn't include things like a left turn at a light, or the yellow light dilemma, or traffic emerging on, because they add complexity, and although interesting, they were not the primary focus on general driving performance that we were looking at. And so there are other events that we can continue to look at as we mine this data set for other things, but this analysis focused mainly on general driving performance. And so the first thing we're looking at is lateral control, and we see steering frequency here is the first measure we have. And so this is a representation of a very complex math, and I always have a little more trouble getting my head around this than what I ought to. But basically, it's the frequency at which we cut the power in half from that standpoint. So it kind of represents where some dominant steering frequencies are at. And what we see is that for the Alprazolam compared to placebo, we see that under the influence of Alprazolam, we're getting higher steering frequency cutoffs, representing a little more steering input on the part of those drivers as they try to control the vehicle.
And in this figure, Dr. Brown, Alprazolam, or the drug, is red.
Yep.
And the yellow bars
represent the significant differences. So we saw significant difference for urban curves, interstate curves, dark rural, and rural straight. Not much for the urban or the interstate. And we also saw, as you'll gather as we go through this, we're not seeing any effects of the hydrocodone, acetaminophen, as we go through these driving performance metrics. We'll show an effect size table at the end that will provide a little more context on that front. So when we look at lane departures per minute, what we see here is, again, for 5 out of 6 events we looked at, we see higher numbers of lane departures per minute when we are looking at Alprazolam versus the placebo condition. And then as we take a step back and look at one of our standard measures, as Gary referenced earlier, a lot of work on drug driving comes out of Europe, and one of the standard measures is standard deviation lateral position or lane position. which is kind of a representation of how much weaving you're doing in your lane. And so the higher that number is, the more weaving you're doing in your lane. And that's been shown to be highly predictive of impairment as it relates to alcohol and other drugs by our friends Verster, Ramakers, and their colleagues over in Europe. And we've shown it across the drugs we've tested as well. SDLP tends to be very indicative of impaired performance. And here what we see is at interstate and rural environments, we see that increased variability or significant increase in variability for SDLP for alprazolam relative to placebo. And I guess I should have pointed out as we went through there, what we've got our nice box plots with the data points overlaid on them in those little circles that are scattered along the line. So that gives you an idea of what the spread of the data is as well.
Not to overinterpret, Dr. Brown, but any comments in your experience with this measure, the tightness on the controls and then the scatter on alprazolam? Strike you?
You know, I think, you know, one of the things we know from looking at some of the other impaired driving or drug driving research we've done is that there are different effects for different people. And so the drugs don't always necessarily affect everyone the same. And so we tend to see that widening of the spread a little bit for the drug driving condition, with, you know, tending to get those oftentimes those longer high end tails on the data for the So one of the questions that just came in, we'll try and address that right now. So could the participants identify whether or not they were on placebo or active drug? They could not identify it from the capsule itself. The capsules were set up so that for the alprazolam, the placebo capsule looked exactly like the alprazolam. Same for norco, acetaminophen. They were capsules, so the capsules look the same to the drivers. Their ability to tell the difference, you know, it's similar to any other drug. You know, they may feel the effects. Could they necessarily know, if they hadn't had previous experience, that they were on the alprazolam versus the norco acetaminophen? Not unless they knew what the effects were.
Tim, do we have the data on sedation in this presentation?
We talk a little bit about it in a couple slides. And so so the question is whether or not they could feel the sedative effects. They could guess, but again, it would depend upon whether or not they knew how the drug affected them. Norco can cause some sedation effects. And so it would depend on the individual whether or not they could tail it out. But
and it's a good question, but what is important is that there was placebo and 2 active drugs, both of which may have had sedation. Now the subjects could not tell. They might guess whether they had active drug, but they could not tell which it was, generally from one administration. And I think you'll see that there's a disparity between the results. So that in itself is interesting. 2 active drugs produce different results in these measures.
And so the last measure that we're going to look at, or dependent measure for driving, is going to be our alprazolam's impact on longitudinal control. We saw relatively more modest impacts in terms of, you know, the measures that showed effect. And so accelerator pedal holds is basically, you know, when you hold the accelerator pedal at steady state for a period of time, what we saw is that there were fewer holds, and these are in absolute counts over the events. And so the longer the events, the higher the numbers are, which is why rural straight winds up being so much larger than the other ones. But, you know, when we're in steady state, we often get to that spot where, you know, you make small adjustments and you hold there. You know, what we saw, at least for this rural straight at the end, where you're trying to basically maintain speed over a 10-minute period, and then at the very urban area at the beginning, is we saw fewer accelerator pedal holds. So there may be more chasing of the desired speed there, resulting in fewer holds. The next one is, as I try and slide through them, is one of the more interesting ones. And we didn't graph this one out because it's just we had an effect for only one of the events. But this is a measure that looks at how much of the time is spent at greater than 10% above the speed limit. And so for Alprazolam, what we saw is that on average, they spent drivers in that on their Alprazolam spent 74.2% of their time, more than 10% above the speed limit for the final segment of the drive. So that last 10-minute segment, they spent a fair amount of their time going faster on average. Whereas for that same event for individuals on the placebo condition, they only spent 0.5%, more than 10% above the speed limit. And so, when I talked earlier about the fact that it takes 10 minutes no matter what, the folks on Alprazolam were speeding. And if we tie this to some of our drowsiness research and some of the anecdotal comments we had from people in that study, which we had a larger sample for, they, not being aware that it's a fixed 10-minute drive and just wanting to get done faster, would drive faster to try and finish earlier because they realized that they were impaired from drowsiness in those cases. And we're seeing a similar thing here with the Alprazolam, which is higher speeds to potentially try and finish the drive sooner while feeling that drowsiness kick in. And so this is Cohen's d effect sizes. And so one of the questions is always, is this an issue where we just have a small sample size and we have some modest to large effects that we're just not able to see because our sample is too small? And what we've got here is we divide it between Alprazolam on the left-hand side and the Hydrocodone and acetaminophen on the right-hand side. And I included a handy-dandy guide there because I always have problems remembering what sizes are the different effect sizes representative of. And so what we see when we look at the Alprazolam side is we see a lot of effects that basically fall in that large to huge range. And then we've got a scattering of things, particularly on this percent speed high. We don't see much across any of the subjects there in the Alprazolam condition until you get to that final event. But we see basically this representation of relatively large effects that we're able to detect. When we look at the Hydrocodone acetaminophen, we do wind up with smaller effects there. And as Gary said, this wasn't the largest. This wasn't the largest dose that you could get of the Hydrocodone acetaminophen, but it was, as I recall, Gary, and you can correct me from the review by Gary and Andy, that these were the most common dosages.
Well, actually, it's not very tiny. The combination of the acetaminophen and hydrocodone can be either 5/325, which is 325 of Tylenol and 5 of hydrocodone, or 10/325. So this is a significant dose. Now per day, you probably could have 40 to 60 milligrams, but the 10 milligrams is not insignificant. And believe me, I believe our IRB took note of that. Now, how does that reflect people out there driving? You have so many questions. The metabolism is affected by chronic use. Each individual in terms of absorption, metabolism. But the 10/325 is a healthy single dose.
So this moves on to our color man. Gary is going to continue with some more comments on the mechanisms. And this is always one of the questions that pops up is why might these drugs have an impact? And so one of the things that's important to understand is kind of how these drugs act. And so We're going to turn it over to our color man Gary here to provide some insight on the mechanisms.
And as the ESPN color guy Chris Berman says, I'll try and stumble and bumble my way through this because it is complicated, and it's in my view rapidly changing. I've been in pharmacology for almost 40 years, and the changes are incredible down to the genetic basis. But basically, Alprazolam affects the benzodiazepine A receptor of the, I should have put in GABA system, but it's a well-known receptor. And it is numerous throughout the body, both in the central nervous system and in the periphery. That system is probably the most robust inhibitory neurotransmitter system in the central nervous system. The is much higher, but there's a comment on the doses. Higher doses, I mean, let me address your comment later. I'll distract myself. Hydrocodone affects the mu opioid receptor, and there are several opioid receptors. They produce pain relief in a central way and also can have sedation. So if we look at the effects of Alprazolam, and again, you understand that these neurotransmitter systems project throughout the central nervous system and into the periphery. We know that it causes and relieves anxiety. It's probably one of the reasons it's most often prescribed. Muscle relaxation too in the periphery. But then there's the interesting central nervous system effects of sedation and amnesia. Hydrocodone, meanwhile, produces analgesia. It's excellent for that. And sedation at these doses. Now, the effect of a drug is very complicated. If I can recall, some of the factors would be there's genetic factors involved. There's a dose factor, as Dr. Ferlin is pointing out. There's an exposure factor of how long this particular subject has used acute or chronic. And lastly, there's a mode of administration. We could have looked at the end of the day after someone takes Xanax 1 milligram 3 times a day, and then you have that build up in the metabolism, or hydrocodone. So considering all that, the mechanisms of why there's a disparity between the effects, and I really didn't expect this, is Alprazolam affecting driving at a cognitive level? I mean, it makes sense that you have not only sedation, which is probably an easy one to jump to, but what about the amnesia effect? What about the interference with cognitive functioning? What about perceptual changes? And then as well as the effects on the muscles. So there appears to be more of a broad, what would I say, spectrum, broad range of possible effects of this drug. Hydrocodone, at this dose, we're looking at mostly sedation in the central nervous system. That's speculation, somewhat off the top of my head. But to understand that, we'd have to design studies that use both drugs, take a look at these variables, and then measure for various cognitive, memory, peripheral reaction time parameters. So the comment is the patients in Canada use higher doses. Interesting. We'll have to talk to the pharmacist up there. Nausea? That's a good question. On the single dose, I can't answer that, to be honest. We'd have to ask our.
So we did capture nausea questions as part of our simulator sickness questionnaire. We didn't observe simulator sickness from these subjects in the drive, but we do have the nausea question we could look at. So Andrea, we can take a look at that and get back to you with what the data show us on that front in terms of what any changes in the nausea scores or observed nausea for these patients when they were on the hydrocodone. So
it's a good question. It's one of the side effects of the narcotics. Certain narcotics in certain persons produces nausea. I couldn't tell you the exact mechanism of that and the relationship of the SIM.
So as we wind this down, because Don told us to target 40 minutes, and we're at 39, so we got a little over a minute to to wrap this up, so we have time for questions here at the end. The basic conclusions were that alprazolam did negatively impact driving performance. There were no observed there's no observed effects associated with the acetaminophen at these doses in normal healthy subjects. I think that's important as we look at this. Is that we're not looking at chronic use. We're not looking at the impacts with pain. Further, we didn't see an interactive effect, and the general sedation remains an obvious and often confounding pharmacological effect. It's hard to separate out, what part's the drowsiness aspect and what part is other aspects of the drug working. So,
And Dr. Ferlin, what dose would you typically see in Canada?
okay, so we had a question on no interactive effect, and so we were looking for whether or not the combination of these two would create a larger impact than either drug on its own. And so we didn't see any interaction between the two drugs. So when we looked at the dose of alprazolam combined with acetaminophen, it basically, the alprazolam effect dominated, and the acetaminophen didn't either increase or decrease the effect of the alprazolam on driving performance. And so that's what we're looking at there when we said no interaction effect. It didn't it didn't make it either less impactful or more impactful for the alprazolam when they were on the acetaminophen.
I see it's an interesting discussion on the potency of the narcotics and the equivalency of morphine. That would be an interesting paper and topic in itself, because hydrocodone is less potent than oxycodone, and then less potent than some of the others, oxymorphone. But it's complicated because there are subjects that metabolize these drugs in different ways. There's some that would not metabolize it, and I don't recall those totally off the top of my head. So it's a complex interaction, not to mention the interaction with pain. I think would be an incredibly interesting subject for further study.
So this is the last slide we've got. The work that we want to do in the future, specifically relative to these two drugs, is to finish the work on the blood levels and performance, and see if there's some differential relationship as we take into account what the blood levels were for each individual. We still are going to do some work on analyzing the brain activity from the EEG while under the influence of the drugs. And driving performance effect on patients with chronic pain, I think, is going to be an important topic moving forward as we move away from the normal healthies. Because one of the things that you always deal with here is when they are when you've got somebody who's a patient rather than a normal healthy, you're treating some disease state. And so their baseline condition when they're off the drug is different than a normal healthy's baseline condition. So if you're driving while fighting the pain and that's distracting you from driving, that is a different situation than somebody who doesn't have any underlying pain that you're trying to treat. And so that's always a struggle. One of the challenges there is obviously if somebody's on a pain medication for medical reasons, the bar for trying to remove them from that drug so you can study something else is a little high, and so you just have to figure out how to carefully design those studies. So
the comment is the metabolism of hydrocodone is variable. Absolutely true. And we do have the blood levels we can look at as a follow-up. Then again, blood levels not always indicate the level in brain and at receptors.
So that wraps up our presentation here. We're open to any questions. Jacob, I'll